Thank you, chairpersons. Thank you, Dr. Mohan. It's really a privilege and an honor to be here, and I thank the organizing committee. So I'm going to start you off as why is it important to learn about CGMs, about technology, about artificial pancreas. So I'm introducing the topic to you to the how, what, and why of abnormal glucose physiology. So basically, if you understand abnormal glucose physiology, you can apply precision diabetes using technology and physiology to inform the practice of the patient. So that's my interest. I'm going to skip that. Okay, so I have learning objectives: why, how, what. I always ask these questions because I am a researcher, a scientist, and I ask why. You have to understand the abnormal glucose physiology to use the fundamental principles of CGM profile interpretation. How would you do it? You use the CGM, and what is? Use the CGM and knowledge of pathophysiology to guide your therapy. So basically, the approach is identify the underlying pattern of dysglycemia in the patient because no two patients will be the same. Determine whether the cause is physiologic, is it behavioral and or pharmacologic, match the treatment to the defect, initiate the treatment, adjust the treatment, and then assess the treatment. So why use continuous glucose monitoring? So CGM is required to measure, transmit, and aggregate accurate and verified glucose data in order to identify the underlying defects that characterize diabetes. So you can improve the diagnosis, you can initiate, adjust the therapy of the patient, and understand whether use the CGM to measure and understand the efficacy of the treatment. So it has many uses. So I'll give you a clinical problem. This is what most of us see in our practices. So a 50-year-old man comes, his BMI is 30, so he's overweight, of course, presents, his fasting glucose is 200 milligrams per deciliter, despite his best efforts in maintaining the current therapy of metformin. So he's on metformin, which is what we like to put our patients on. And he has noticed that his glucose concentrations 1 to 2 hours after a meal commonly are in the range of 250 to 300 milligrams per deciliter. So he has fasting hyperglycemia, postprandial hyperglycemia. So what are the next steps? Okay, so if I were to throw this out, many of us, given the current scenario now, will not be doing fingerstick glucoses. We would probably say, let's put him on a CGM. So we put this guy on a CGM and we look at what comes out of the CGM. So this is his ambulatory glucose profile. And I'm not so bothered about the CGM analytics. I'm more talking about look at the profile. So if you see his profile, he's got hyperglycemia, just like I described to you as fasting, postprandial, his excursions are really high. So this is the whole picture and it gives you an estimated A1C value. Not to worry about that. Now look at the dysglycemia using daily profiles. So you see day to day, I don't have a pointer here, but you can see he has fasting hyperglycemia, he has significant postprandial hyperglycemia. So if you look at every day, all those yellow bars, he's got high sugars all the time. Okay, thank you. Yeah, so you can see he's got, okay, so this is daily patterns. You're getting a picture now of what's going on with this guy. And this is matching the clinical profile that I just gave you that he came and told you. So the question is, remember, I'm the physiologist. So I'm going to tell you what causes this fasting and postprandial hyperglycemia and what are the metabolic defects in people who have diabetes or pre-diabetes that relate to these patterns observed on CGM. So you get the pattern of CGM. You have to know why is it like that. So I'm telling you what are the clues to that because that's the research I have done. So if you can look at this slide, this was done in our lab many years before I joined the lab. I joined in 95. Dr. Butler was there in 91. This is a very classic slide which everyone can relate to. So if you look at this, there are three groups of people. There's a no diabetes, which is in blue. There's a pre-diabetes in orange. And there's a yellow, which is people with type 2 diabetes. So if you look at the fasting state, not surprising, this is normal sugar, this is elevated somewhat, and this is very high. 10 meaning about 180 milligrams per deciliter fasting. So what happens at zero time? They gave these people an oral glucose tolerance test. They gave them a glucose challenge. And what happened after that? If you look at the healthy person, in response to that challenge, put out a nice amount of insulin, beautiful response, brought the blood sugars down by 2 hours, blood sugars normal. And if you look at the orange bar, this is the orange person who has prediabetes. Their excursions took time, so there's absence of that first immediate response to the oral glucose or meal, whatever you give, and delayed insulin response. Okay, so that caused the sugars to stay up and remain high for a long period of time and then came back to normal. If you look at the person with type 2 diabetes, sugars are high to start with, and look at what happened to the insulin. It barely came up, it crept up slowly, and then this caused this high rise, stayed high, sustained hyperglycemia postprandially, and stayed high for a long period of time. So this is glucose and insulin. The important one that everybody forgets about is glucagon. So what happens to glucagon here? If you see in a normal healthy person who doesn't have diabetes, as soon as you feed them something or give them a meal or whatever, glucagon suppresses. This is normal physiology. Glucagon is supposed to suppress when insulin goes up. But insulin goes up, glucagon suppresses. What happens with the person with prediabetes? Sugars are high, insulins take time to come up, glucagon is not normal, it's high. See the orange bar? So much difference. This is also giving rise to that postprandial hyperglycemia that you're observing up here. And if you look at the yellow curve, there's absolutely no suppression of glucagon in people with type 2 diabetes. And this is an abnormality that also gives rise to this. So there's double whammy. There's very little insulin, there's too much glucagon, and you have postprandial hyperglycemia. So I'm showing you why those glucose profiles on CGM were that high, okay? That could be one of the reasons. Now, these are studies that we did when we were at Mayo. And what I did was I took people who have so-called no diabetes, have mild type 2, meaning fasting glucose is maybe in the 120, 130 range, 140, no more than that. And severe is much higher, about 180 milligrams per deciliter. And what I showed was that both these groups of patients have hepatic and extrahepatic insulin resistance. What do I mean by that? Their liver was putting out more sugar even when they were fasting. So fasting endogenous glucose production was very high. So here are the blood sugars. Look how high the EGP is. It correlates to the blood sugars. This is a normal healthy person. This is someone with mild diabetes. This is severe type 2 diabetes. Then there were studies that Anand and I both did together. The studies are very complicated. I'm not going to tell you the details. They're all published. So we put in hepatic femoral artery catheters, and we looked at what happens in the liver in splanchnic balance technique. And what we showed was splanchnic glucose uptake. So if you maintain hyperglycemia, so you pretend that you're feeding them, so you do a sustained hyperglycemic clamp with various doses of insulin, splanchnic glucose uptake is lower, meaning the splanchnic bed is not taking up sugar. That means more is coming out into the circulation, which is causing the postprandial hyperglycemia. And doesn't matter how much of insulin you give, even at higher doses, there's less splanchnic glucose uptake. And then we did another series of experiments that I did where I did a dose response of insulin, and I showed that under hyperglycemic, hyperinsulinemic conditions, the liver in a person with type 2 diabetes puts out more sugar. So this is in the postprandial condition. We are mimicking postprandial situations. So despite the higher and higher doses of insulin, which is physiological, the liver puts out more sugar and glucose uptake is so much lower. So it's significantly lower. So the muscles are not taking up enough sugar and the liver is continuously making more sugar despite the fact that there is sugar in the systemic circulation. So these are the defects that you're seeing when you're looking at that ambulatory glucose profile. And very recently I published this where I took people who had diabetes and those who didn't have diabetes, and I did a diurnal pattern, meaning I studied them 3 occasions, 3 days in the CRU, 9 meals, gave breakfast, lunches, and dinners, and showed that insulin sensitivity in people with type 2 diabetes is low all night. Breakfast, lunch, dinner. Disposition index is lower all day. Look at where the healthy person is and look where the type 2 diabetic is. Breakfast, lunch, dinner. And look at hepatic extraction, which is a clue to all this. is very low, and the beta cell response to glucose is low. So all this put together is what you're seeing in the CGM profiles. I'm just interpreting it for you under physiological conditions. So when I showed you this dysglycemic slide, I showed you the dysglycemia using the daily profiles. Now you're beginning to understand why was this patient's blood sugar so high in the fasting state and postprandial. It's possible they have impaired hepatic, extrahepatic insulin action. They have impaired insulin-induced suppression of glucose, impaired insulin-induced stimulation of muscle and splanchnic glucose uptake, and beta cell dysfunction. So all these things are giving rise to these profiles that you're seeing in the patient. It's not a single cause. And that is why it's important to know it's not a single thing. It is multifactorial. So that therefore, when we treat patients with type 2 diabetes, we have to use different medications because each of those defects are related to a different drug that can address it. So no one drug will work. No two patients are alike. So you have to use different medications. So there are drugs that can suppress glucose production. We have drugs, we call them insulin sensitizers. We have drugs that can be secretagogues. We have drugs that are SGLT2 inhibitors now, can increase the renal excretion of glucose to combat hyperglycemia. We also have DPP4 inhibitors and GLP1 receptor analogs. And of course, so all these drugs together, that's why we use multiple drugs to treat diabetes because the disease is multifactorial. So if you come back to what is a normal glucose profile, a very famous professor once said, if the human body is spending so much energy to maintain the blood glucose level within such a narrow range, look at this in healthy people, how narrow the range is. It is because otherwise it would be deleterious to health. So our goal is to get blood sugars down to as near normal as is possible. And so at least my understanding of this is precision medicine approach to achieving near normal glucose profile is identify the dysglycemia in terms of duration, its frequency, distribution, and magnitude by putting people on CGMs, determine whether the primary cause is physiologic, like I told you, or behavioral and or pharmacologic. They're eating erratically, they eat wrong types of food. That's all behavioral, that can be corrected. Match the treatment to the defect by relying on the natural history and the experiential data with the CGM, initiate treatment, monitor with CGM, adjust treatment using CGM data, and assess treatment by comparing to the baseline of that patient. So I'm going to leave you with this final thoughts that, Dr. Robert Unger, he was the father of glucagon as we know him, pointed out in 1975 when he gave his Banting lecture. I was very young. I was not even, I think, middle school at that time. He said, nature makes a substantial effort to avoid hyperglycemia throughout life. And therefore, I believe that therapy directed at correcting specific metabolic defects is more likely to be successful in either treating or preventing diabetes than managing everyone the same way, regardless of the underlying cause of their hyperglycemia. So thank you for your attention.